Recording. Dr. Collins, you should be the host. Got it?
Got it.
Wonderful, wonderful. Let me share my screen, pull up my PowerPoint. All right, are you all able to see the screen?
Yes.
Wonderful, wonderful. Well, good evening, everyone. My name is Michelle Easton, and you are in for a treat this evening. We have the Chicago as well as the New Orleans area citywide programs of DREF, Research Matters for All of Us here this evening. We are doing this joint event, the more the merrier. And so we are joining both Chicago and New Orleans for evening of information as it relates to cervical health. We have lots of information to share. The first thing that we want to do is to, of course, welcome you to this second seminar webinar that's happening in the month of January. We're going to take a deeper dive into the All of Us research program. For those of you who are returning, we'll dive a little bit more deeper into the All of Us program and speak and hear from a health provider organization. If this is your first time joining us, welcome, and it's okay. We'll get you all caught up with all the information that you need. The conversation that we're having tonight is relevant, it's important, because there's an increasing, of course, concern related to morbidity and mortality of persons of color who are suffering from chronic diseases, and the disparity is huge. And so we think that informing, providing education and information is one way to get people more engaged and ready to act, because we can all do our part to help decrease health disparities. The DREF Research Matters for All of Us program, it's an initiative funded by the NIH All of Us Research Program. And as mentioned, we are doing our best to try to decrease health disparities. As you'll see on the screen is a picture of Dr. Collins and myself as we are serving as the Chicago coordinator, citywide coordinator, and the New Orleans citywide coordinator for the DREF Research Matters for All of Us program. What you'll see is a picture of the flyer that we hope you saw and that helped to draw you in with us tonight. You're going to hear from Dr. Adrienne Ray, who is going to be phenomenal in the information that she's going to share with us and inspire us to really act to prevent ourselves from not having healthy lives, particularly when we're talking about cervical health. On this slide, you'll see the members of the DREF Research Matters for All of Us, our citywide coordinator core team. Carolyn E. Lewis serves as our DREF president, and you'll see the other persons listed below her name are all persons who provide their time and talents to ensure that our program runs without a hitch. So we want to recognize those individuals and thank them for their service to DREF and to the NIH program. What you see on the screen are the 12 cities that are part of the DREF program. These 12 cities are around the United States. They are in Denver, Colorado, Miami, Florida, Atlanta, Georgia, as you know, Chicago, Illinois, Shreveport, Baton Rouge, and New Orleans, Louisiana, Boston, Massachusetts, Detroit, Michigan, New York City, New York, Houston, Texas, and Milwaukee, Wisconsin. So those are the 12 areas where we're working together to do all that we can to get the word out, to spread information and education about health matters that are commonly to have you hear from Dr. Francis Collins. There's a small, short video that I'm going to play right now. So please turn your attention to Dr. Collins.
So much of what we've done in medicine over the years has not really taken into account individual differences. And this is an opportunity to be part of something historic.
Hold on a second. Sorry about that.
An opportunity to be part of something historic. Most studies and most clinical trials have always been with the average white male. So as we start thinking about this in the context of building trust, I think we get back that trust by involving the community, not saying you come to us or we'll just do things to you. We're going to do things with you and in fact, allow that information to be accessible to you, the individual.
You're going to have some individuals that are going to say, yes, good, we're getting in on the ground level of a study. And then you're going to have those that have some trepidations about it. My thing is to bring them aboard and let them know that this is for the greater good for them. We have input and, without input, there's no buy-in. And without buy-in, there's no commitment. Without commitment, there's no success.
Tuskegee happened. We're not trying to hide that or sweep it under the rug, but communities of color will be at a disadvantage if we do not find ways to get by that, whether the focus is asthma, whether the focus is infant mortality, whether the focus is diabetes, cancer, or heart disease. Communities of color are disproportionately impacted by them.
It has always been playing catch up to make sure that they're even getting access, much less minimum service. Low income, underserved, and people of color are oftentimes very generous in giving something if they understand it. And they always do so with the intention that knowing this is not just about me, this is not just even about my family, it is about helping the community down the road.
Being able to bring the Asian American population who is never at the table, not only to contribute to science, but to contribute to our ability to understand the nuances within those populations. I think it will provide a huge national data set so we can ask questions and make discoveries about healthcare that will better their own personal health and those of the communities that they are part of.
Diversity strengthens the science. It could bridge some civil rights issues and inequities in healthcare across all races and ethnicities and culture.
As a community of color, underrepresented, hidden, underserved, what would happen if you were not at the table? It is an issue of equity and it's an issue of justice as well.
It is important for minorities to be a part of this, or we will again be left with medications that are created for really other populations. I'm hopeful that we will be overwhelmed with folk.
Absolutely beautiful video that I hope helped you to see that this is really about trying to improve the health of our loved ones and of ourselves. And the real aim is to improve healthcare and to decrease health disparities. It is hoped that this ambitious opportunity is going to be a catalyst that will fuel a new approach to how we provide care, and that's individualized prevention and treatment, and that's something called precision medicine. The next slide is going to be a video from former President Barack Obama, and he's going to talk a little bit about precision medicine.
Something called precision medicine, in some cases people call it personalized medicine, gives us one of the greatest opportunities for new medical breakthroughs that we have ever seen. Doctors have always recognized that every patient is unique. And doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking our temperature? And that's the promise of precision medicine, delivering the right treatments at the right time, every time, to the right person.
And so I hope what you really heard is that how important this initiative surrounding precision medicine is. It was because of the initiative with precision medicine that the All of Us research program was established by the NIH. And what it really is desired to do is to accelerate research and to accelerate medical breakthroughs. We want to be able to individualize prevention and treatment and care for all of us. And this program will do so by nurturing relationships with diverse populations that reflect a better picture of the United States. It's designed to help to fuel a robust community of clinicians and researchers, and it will be a repository for a diverse biomedical research. So all these resources are going to be put together, and that is part of the All of Us program. The core values of the program are quite simple. One, it's open to all. We want to have diversity in the persons who participate. Participants are going to be viewed as partners, which is a much different approach than just a participant. When there's a partnership, there's more transparency, more communication, more ownership in the process. The research, the All of Us program is designed so that patients and, as we talked about, partners will have access to their own medical information. Security and privacy are paramount, are extremely, extremely important. And of course, we're hoping that it's a catalyst for positive change. So if you were to participate, what would be asked of you? Basically, the ask is for you to participate by enrolling, signing a consent form, and authorizing an electronic health record. You'll be asked to answer some simple initial questions. In many cases, there are physical measurements and maybe even requests of biosamples. And in some instances, the utilization of technology such as digital or health wearable apps will be part of the process. So the questions that is hoped that the All of Us program will help is to answer questions such as, how can we develop better treatments for those persons who are the large numbers of persons affected by some disparities as it relates to chronic conditions? So if you take hypertension or diabetes, we know that that disproportionately affects persons of color, specifically African Americans. What if we were able to develop better treatments? What if we were able to develop treatments that weren't addictive as it relates to pain and the treatment of pain with medications? Wouldn't that be wonderful? And as we know, as persons are aging, the studies are showing us that more and more people are aging, but so is the increase of persons with dementia. So if we could have research that could help us slow or even stop dementia, that would be outstanding.
The All of Us Research Program is an ambitious effort to gather health information from 1 million or more people across the U.S. Researchers will be able to use this information to uncover new, more precise ways to prevent and treat disease and to keep people healthy.
If we delve deeper into where we live, what we consume, what we do, that will have an impact on trying to prevent diseases in the future.
Precision medicine will allow us to get the right medicine at the right time for the right person.
Diabetes, high blood pressure, obesity, illnesses that Black women get and die from needs to be researched.
This isn't going to be some sort of Tuskegee experiment. This is going to be the community working together with healthcare institutions.
So what's the promise for participation? Part of the promise for participation by our partners, yourselves, potentially is to be able to fight disease. Through the process, you'll be able to learn more about your own health. You'll be able to access your own data and also learn about additional research opportunities. What we would love for you to do is to visit researchallofus.org. There's a wealth of information there about the program. Here is some information that we really want you to take a look at. There's a QR code at the top of that slide. We want you to use your smartphone and aim your camera on top of that QR code. And what that's going to do is that's going to put you in touch with a link. And that link will allow you to, one, learn more information. But what we also want you to do is to complete a quick survey. Painless, not very long, but just complete the survey and provide us with some helpful feedback. We do look at the survey results. It helps inform us as to topics to to present in the future. And it gives us helpful feedback. So please take a moment or two to complete the survey. Additionally, if your preference of getting your information is through social media, wherever you're thinking, we're there. Instagram, Twitter, Facebook, we're there. And you'll see on the screen the actual handles for each of those different platforms. Additionally, stay tuned. We have something that's coming up new and exciting that's called pop-up clinics. And more information, you'll hear that from your citywide coordinators in the upcoming weeks. If you'd like to get in touch with the Chicago Citywide Coordinator, Dr. Yvonne Collins, her email address is right there for you, rmchicagocc@gmail.com. If you're in the New Orleans area and would like to reach out to me, my email address is nolarmcc@gmail.com. And don't forget, there's lots of information on the NIH's All of Us research program website, and that's at www.joinallofus.org/DREF. At this time, I'm going to turn the program over to the capable hands of Dr. Yvonne Collins, who's going to take it over from here. I'll unshare my screen and you will have at it, Dr. Collins. Thank you so much.
Good evening, everyone. Thank you again for joining us. I will begin the segment where we focus on our health provider organizations. I'd like to give a shout out to Northwestern, to LSU, and also to our partners we'll talk about a little later. But I'd like to introduce you to Nicole Hunt, who is the project manager at Northwestern, who has worked diligently with me, I think now a year, Nicole, attending most of our seminars, and I thank you for that. And we can proceed.
Thank you, Dr. Collins and Dr. Easton. So happy to be here and be able to join you guys today. And I appreciate you all for taking the time to learn a little bit more about the All of Us research program. So I will share a little bit more about what the next steps are. On the next slide here, next slide here, we have, this is where you can find our locations. This is our participant locations that you can find throughout Illinois, what is known as the All of Us Research Program, Illinois Precision Medicine Consortium, or the IPMC. Even if you don't receive care at one of the health provider organizations shown here, you can still choose any one of these locations to partner with. Then on the next slide, I'm going to go into a little bit more about what participation entails, as Dr. Easton has given us an introduction to earlier. So the simplest and fastest way is to download the All of Us app on your phone, or you can also go to the website at joinallofus.org/Illinois. And so both on the app and website is where you'll create an account, and your account, which is known as your participant portal, is a digital dashboard for the participant journey. And once you create an account, participants will be asked to consent immediately. The consent process is an interactive journey that explains the program and participant rights. This includes choosing if you'd like to share electronic health records. And EHR is important because it gives the most complete record of a person's health. So when researchers can study EHR information from many people, they can find patterns, and those patterns can help to better understand our health. Next, you'll be asked to complete a series of surveys, and survey completion is what will provide researchers with an understanding of your life environment, like how you exercise and what you eat. Surveys are an important part of staying connected with participants and hearing about the changes in your lives over time. The next participants will be given a list of nearby sites, which they can partner with, which I shared with you in the previous slide. So after selecting your desired location, you will then have the opportunity to schedule an in-person visit. And this portion will take approximately 30 minutes and includes, as we previously talked about, basic physical measurements and biosample collection. And if you agree to provide blood, we can analyze the DNA in the samples. And DNA is an important source of information about health that researchers use. You have the opportunity as a participant to receive those DNA results, and it looks at information like ancestry, traits, and health-related information, like if you have a higher risk for certain health conditions or how your body might react to certain medications. And lastly, participants can share data from supported third-party devices such as Fitbit and Apple Health. Both serve as additional sources of data collection. Because the All of Us research program is a longitudinal study, there is large value in receiving multiple data points from participants over time to have a full understanding of the various factors that make your health story, because what works for you may not work for me. And so lastly, if anyone has any questions for me regarding how to join, or you're interested in learning more about what participation entails, please feel free to contact us using the information that Dr. Collins had shared, or Dr. Easton had shared earlier. And also, if you would like the information to our location at Northwestern, I will include that in the chat as well. Okay, thank you very much. And I will hand it back to you, Dr. Collins.
Thank you, Nicole. So I'd like to again shout out our community partners. This is very important work, and it takes more than one organization to do it. So again, thank you to Northwestern, thank you to LSU Health in New Orleans, and also thank you to our partners this evening, the National Council for Negro Women, some of which were on the line. So thank you each for all of the work that you do each and every day. Before we get to our main event this evening, I must read you this disclaimer. The views and opinions expressed by the guest panelists and or presenters do not reflect the views or opinions of the Delta Research and Educational Foundation, DREF. DREF Research Matters for All of Us, the NIH All of Us Research Program, or any of these organizations' affiliates. And again, you can always go to www.joinallofus.org/DREF if you want additional information. As I prepare to introduce our guest speaker, I am going to stop sharing, and Dr. Ray, if you can start to share, that would be great. So Dr. Ray, who is our featured speaker for this evening, was born and raised in Chicago. She went to undergraduate training at Northwestern University and then the University of Illinois College of Medicine, where she's received her MD degree. She's an obstetrician gynecologist and completed her residency at the State University of New York, SUNY Brooklyn. She was an OBGYN practicing at Loyola for over 11 years, where she taught medical students and residents, and then entered private practice here in Chicago. Following 18 years of private practice and a really smart decision, she decided to retire from clinical practice and joined the world of medical management. She's been a member of the National Medical Association for 25 years, the Cook County Physicians Association, and has held offices both locally, regionally, and nationally. She's devoted to the care of her patients, and she's often my roommate when we travel. And without further ado, I will turn the program over to Dr. Ray. Thank you so much, Dr. Ray. You should be able to unmute yourself.
All right. Thank you, Dr. Collins, and thank you everyone for being here. And just as an aside, I just wanted to say that the physicians that are on this call, at least the ones that are in the DREF program, we are all walking the walk. We are all part of the All of Us program. I first found out about All of Us about 5 or 6 years ago through a program that they had at the National Medical Association. And this program, All of Us, is being promoted by the NMA, which is the Organization of African American Physicians here in the US, because we find that it is so important that we get as much information as we can on our people. We are dying. We are dying of things that non-African American people are not dying from anymore. We are sick from things that others do not get sick from. So this is an opportunity for us to find out or find a way to equity. And when I say equity, I'm talking about some type of even ground where we are getting all the benefits of medicine. I'll get off of my soapbox as far as that is concerned. And once again, I do think All of Us is a great program, and I hope that everyone goes to that website. Well, in terms of what I'm going to be talking about tonight, I'm going to go to my own wheelbarrow, which is a gynecologic subject, talking about cervical health. And I'm going to talk about the new cervical testing guidelines. And it is not your mother's pap smear. When we've all had our pap smears over our lifetime, not if it's anybody's favorite thing to do, I'd have to say that I'm a little afraid of you. I'm getting a little feedback right now, but this is something very important to know because, you know, once again, we talked about, you know, being a partner. This is how you can partner with your healthcare provider. The more you know, the more questions you can ask, and the better off you will be in getting information from your physician. So many times, you know, we come home from the doctor's office and we don't quite remember what was done or even what was said. So hopefully, you know, you'll take away something from this where you can actually have that conversation with your doc. So getting started here. Okay, there we go. A little pop quiz here. The pap test is a swab of the cervix. That would be A. B is a swab of the cervix and a pelvic bimanual exam. Or C is a swab of the cervix, a pelvic exam, and a complete physical exam. You know, I didn't expect anybody to jump in and answer this, but I'm going to tell you now, the pap test is A. It's only A. Oftentimes when we go to the doctor, we'll say we're going to get our pap test when we're actually talking about C. But the pap test merely is a swab of the cervix. It's obtaining cervical cells that will be sent to a lab, which will be looked at under a microscope, which will tell us if there are abnormal cells there or not. Some background notes. The pap test was developed by a Greek physician in 1941. By the 1950s, at least here in the United States, the pap test was pretty much in constant use. And the purpose of the pap test was to detect cervical cancer. So your pap tests at that time were actually normal or they were cancer. The cervix is the opening to the uterus or the womb, as you know, and the purpose of the Papa-Nicolau test or pap test was to obtain these cells from deep in the endocervical canal in an area called the transitional zone or T-zone. Just to give you a little bit more background, the leading cancer diagnoses in U.S. women are noted on this list. Now, back in prior to the 50s, when the pap test became pretty much a U.S. phenomenon, cervical cancer was indeed the #1 diagnosed cancer in the United States. So that would have been above breast cancer. Now, these are not the leading cancer deaths that I've had listed here. These are the leading diagnoses. So as we go down the list, we can see that cervical cancer is 1, 2, 3, 4, the 5th most common cancer that women can acquire. It should be noted that worldwide, especially in third world countries, cervical cancer is the #1 cancer among women, especially on the continent of Africa, as well as multiple areas in Asia. So where's your cervix? Okay, so this is a picture of the uterus. And I mentioned that the opening to the uterus or the womb is the cervix. But here you also see the fallopian tubes as well as the ovaries. The ovaries are where you made your eggs or make your eggs. And then the tubes are where the eggs sort of float through to the uterus. If they're fertilized, they'll implant and make a baby. If they're not fertilized, then they basically would come out with the, they would dissolve and come out with the blood that you would note or as menses every month. So this is probably a little bit better picture, just showing also what is used is something called a spatula, which is basically something used to scrape the outside area of the cells. Because you see the cervix not only has an inside canal called the endocervical canal, but an ectocervical component, which is more towards the outside. So I'm hoping that every woman here doesn't have flashbacks of bad exams here. But this is pretty much what happens with the with a Pap test. There's a speculum exam, okay, meaning that the speculum is placed into the vagina. Some people call it a clamp. We're not clamping anything. We're just allowing this speculum to open the vaginal wall so we can look at the cervix. And so that is placed after the patient was placed in something called dorsal lithotomy. You're on your back, your feet are in stirrups, and you're feeling very uncomfortable. But this is what we have. This is what we have to do in order to get this specimen. So the speculum is placed. A cytobrush is used to obtain cells from inside the cervix. And as I mentioned, a spatula is used to obtain cells from the outer aspects of the cervix. The specimen, which a lot of physicians will call it, or the cells from the cytobrush and spatula, are placed in liquid-based media in a container and sent to a qualified laboratory where the cells will be viewed and a report generated and sent to your health provider. And your health provider contacts you. This is the most important thing. If you don't get a report from your health provider, you need to contact that person and tell them you've not gotten your Pap results. In fact, any results nowadays. We have so many ways of getting in touch. We have, electronic medical records. We have My Chart, that you can get on your smartphone. But it is important that you are actually able to generate a report or receive a generated report. Very important. Try not to forget that one is due you. That is your right. So just to give you an idea of what your pathologist is looking at, these are some normal cells. And you can see abnormal cells, which have been, made a different color for us. And essentially, pathologists or cytopathologists who are viewing these are specialty trained in doing this. Now, some of these are actually read with something called artificial intelligence, meaning that the machine actually reads it. But for the most part, this is overseen by a cytopathologist, and it has been shown to be very effective in getting us an answer, trying to go ahead. So really the point of this lecture tonight or this talk tonight is to explain why this isn't your mother's Pap anymore. We know that the Pap test was invented to diagnose cervical cancer, but that goal has changed. The whole idea of preventative health care is to identify problems before they become problems. In other words, We want to find the precancerous cells or pre-malignant cells and treat those prior to them becoming cancer. We want to prevent cancer altogether. And this has certainly been the case, especially in the past almost century now, over 70, 80 years. So cervical screening has evolved into a true preventative health measure due to human papillomavirus testing, algorithms developed with inputs from experts directing follow-ups for these abnormalities, and treatment of cells prior to them becoming cancer. So what is human papillomavirus, or HPV? It is a viral infection that infects the cervix. In 99% of the cases, it is the cause of cervical cancer. HPV has several subtypes, but there are two major high-risk subtypes that are most commonly associated with precancerous changes. And those are the ones that are going to be most commonly reported on a report that's given to you if you're found to have human papillomavirus. So we're looking at HPV 16 and 18. These HPV subtypes were discovered in the 1980s. HPV co-testing with cervical cells, meaning the Pap test, it was introduced in 2003. We really didn't, I'll be honest with you, in 2003, while we knew that HPV was important, we really didn't know what to do with that information. But a game changer was on the horizon. So the game changer was the HPV vaccine. The vaccine was called Gardasil, and it was made available in the US for girls and young women ages 12 through 26 or 27 in the year 2006. The Gardasil vaccine protected against 4 subtypes of the HPV, 2 high risk and 2 low risk. Gardasil was approved for males in 2009. Cervical cancer, after this period of time, and fairly quickly, we're looking at within about a 6 to 10 year period, which is really fast in medical speak, we saw cervical cancer numbers decreasing, but also precancerous numbers decreasing as well. I should put a note in here that the United States was not the first country to use Gardasil or to use a vaccine against HPV. A lot of information came from Australia and New Zealand, which had started using the vaccine probably a good 7 to 10 years prior to when it was made available here in the US. And so a lot of the information from their studies did note that their cervical cancers numbers were decreasing. And in fact, they had very impressive numbers in Australia where they actually had no cervical cancer in those patients who had been vaccinated, as well as the number of precancerous numbers decreased, which was very exciting to know about and something that we knew that we needed to get here in the US. There was another vaccine that came out, but it was discontinued because Gardasil had such a hold on the market, number one, but also Gardasil protected against 4 subtypes of the HPV virus, whereas Cervarix only protected against the 2 high-risk subtypes. Why is it important to protect against the low-risk subtypes? The low-risk subtypes are actually associated with genital warts, and genital warts are quite prevalent. In other words, a lot of people have them. Well, wouldn't it be wonderful if we could sort of like take care of that too and get rid of it? And so that's why Gardasil really sort of beat out this Cervarix. This particular Gardasil was discontinued 4 years ago after Gardasil 9 was introduced a year prior. The Gardasil 9 has protection against more of the high-risk subtypes. And the idea is to cover as many as possible because it also was expanded in terms of age range to cover both, to cover girls, boys, young women, and men ages 9 to 45. Now, in that older group, we would have to anticipate that they may have already been exposed to HPV through sexual activity. Well, the hope was, well, we may not be able to protect you against 16, but we can protect you against 18. We may not be able to protect you against 31, that was another subtype, or another high-risk subtype, but we know that we're going to protect you for something. So Gardasil 9 has once again FDA approval, and it is pretty much it's pretty much what is used today as the gold standard. Okay, so after these game changers, meaning that learning how to check for HPV, but also having this HPV vaccine, there were Pap test recommendations that came out in 2012, and essentially it used algorithms based on the result of the cervical swab. Co-testing was introduced, and that means you check for the cells and your HPV in order to stratify the risk, and it sort of would tell you which way to go using this algorithm. And these algorithms were pretty much like following a recipe in a cookbook. And it was pretty, how can I say, it really didn't take in account the newer things that were coming out as far as the newer vaccines or the newer ways of evaluating and checking abnormal cells. But at the time, it's what we had. Those with high-risk HPV were then advised to have further evaluation with something called colposcopy or colposcopy with biopsy. Now, the good news with all of this is that as a result of this, there's been even a better or significantly decreased cancer and precancer diagnoses. It's not down to zero, okay? We're still going to have some patients who come to our offices and are diagnosed with cancer. But if they've had the vaccine, the risk is going to be a lot less. One thing that that concerns all of us is, who is still getting cancer, and that unfortunately does include African-American women, poor white women, in terms of the Latina population. There is also a higher risk than that of middle class to upper class white women, who typically would have had not only increased access to their cervical testing, but also the Gardasil. But also it's in that community, in the middle to upper class communities, there tends to be a little bit more acceptance of this. And that has been the biggest challenge in terms of convincing or teaching or giving the information out to our African-American community that this is something that is important for our youth in order to prevent cancer in the future. I mean, there's really not a whole lot that prevents cancer. This is a true cancer prevention modality, and I can't stress enough that getting vaccinated definitely will help our community. Now, getting back to cervical testing or cytology testing, there were new recommendations made in 2019. And this was a good thing because we know that there's been so many, how can I say, there have been so many modalities that have improved in terms of looking at the cervix, in terms of the vaccine, in terms of getting this, the modalities to collect a pap test and getting the vaccine out to more of our population. We knew that things were changing. And because of this, these new recommendations were published in 2019 after evaluation, because it was determined that testing for the high-risk HPV was enough. Co-testing with cells is no longer necessary. Now it's the same thing. You're still going to have to go to the to your health provider. You're still going to have to get up on the table, get into that position, have a speculum placed, and then have that swab done. But it's going to be testing for the high-risk HPV. The recommendations to do this, it's felt that it streamlines the management of abnormalities, but it also allows for better personalized risk-based management. The recommendations also allows updates as the technology improves, and the acknowledgement of the use or non-use of Gardasil vaccine. So who came up with this? And I always, I would always tell my patients that none of these recommendations are necessarily something that I came up with. I'm just not that smart. We're talking about a lot of organizations that have many members who actually get together, look over the data, they're doing the research and looking over the data, they're sharing data, and they come up with these recommendations that they feel are going to help the majority of the population. And these groups are everyone from the American Society for Colposcopy and Cervical Pathology, who actually puts out the papers. Everyone sort of comes to that group, but we're talking about American College of Nurse Midwives, Nurses for Sexual and Reproductive Health, the American College of OB-GYN, clinical pathologists, cytopathologists, and the list goes on. And I just wanted to put this in here because, when your physician is making a recommendation, that particular doc has, hopefully read the literature, has some idea of where he wants to, what he's going to do as far as the care of his patients. But there should be some type of reason why the doctor has decided to go that way. And having read, the literature from these different organizations who are pretty much on the same page, should give that physician not only knowledge, but also the power of knowing that he or she is telling his patient panel the right thing and recommending appropriate treatment. So the goal is to diagnose treatable abnormalities. Screening is initiated now at 25 years old. Now in 2012 and prior to that, the age was 21 years old. And I know that some are gonna say, oh my gosh, my daughter, I'm just 22 years old and I'm sexually active and I wanna have a pap test. And there are going to be some who do have pap testing. Now, the issue is that depending on what that pap test shows would determine what would be done. And so someone who is 21 and has a result is probably going to have, the recommendation is going to be different than someone who's 45 and has the same result based on risk. The risk of someone less than 25 years old of getting cervical cancer in that time frame is only around 1%. So it's extremely low. Whereas after 25 years, it starts to increase. We're talking about 4.5% to the time that they're in their 30s, where it is at its highest. So so screening is initiated now at 25 years old instead of 21. The screening is to consist of primary HPV testing only. So when they do that swab, they're not going to look at the cells. They're just going to look at whether there's HPV present or not. And that's every 5 years until age 65, provided everything is normal. If it is not normal, meaning that HPV is present at someone age 65, then that 65-year-old will continue to have Pap testing or HPV testing. If the primary HPV is not available per your doctor, then your doctor should continue what he or she's been doing with cytology and HPV co-testing every 3 to 5 years until HPV testing is available, because the other is going to be phased out. Everything takes time. It takes time for physicians to get used to it. It takes time for our patient panels to get used to it. But this is what's happening, and just get ready for it. So as I mentioned, testing is going to stop at age 65 as long as there's been no evidence of moderate dysplasia, meaning just abnormal cells in the past 25 years, and negative or normal cervical screening for the past 10 years. Positive human papillomavirus, HPV, and or abnormal cytology will be assessed in accordance with a risk-based management guideline, which may include colposcopy. I know I'm throwing out all these words for you, but I promise we're going to get back, and hopefully you've taken some notes and asked me some good questions that I will try to answer. Sometimes the best way to explain what's going on here is to go through some cases. And so this is real simple stuff. So case one, this is someone who's 22 years old with atypical squamous cells of undetermined significance and positive HPV. Now, already I see that this person is 22 years old. So she is younger than what has been recommended for the initiation of Pap testing, but she does have an abnormal Pap test. So what are the next steps? So to follow the current guidelines, we know that the risk for premalignant change is about 1% in that time frame. So the recommendation is for follow-up cytology and HPV testing in a year. So this is someone who will be evaluated outside of the guidelines, but once again, we're providing that individualized follow-up because of that abnormality. So in case two, we have someone, AM is a 45-year-old female with atypical squamous cells of undetermined significance, abnormal, funny looking cells, I like to call them, and positive HPV. So just the same thing that the first case had, except this is an older person. Well, the next step for this particular patient is going to be something called colposcopy. Now, when you're 45, your risk for acquiring cervical cancer within the next year is going to be anywhere between 8 and 12%. So is that 50% no? Is that 100% no? But in medical speak, 7 to 10% is pretty large, or 7 to 12% is pretty big. So this is someone who is going to need to have a little bit closer view of the cervix. So we do this with colposcopy, and I'm sorry about the phone ringing in the background. Colposcopy is a machine that provides a magnified and illuminated view of the cervix to assess for abnormalities following an application of acetic acid. Essentially, a speculum is placed into the vagina. We actually wipe off the cervix with a cotton swab that has this vinegar solution on it. And then the vinegar actually will dehydrate the cells. And so we're able to look at those abnormal cells and determine if a biopsy needs to be done or not. If we see something that looks, that needs further evaluation, we'll take a pinch of tissue and send that to pathology. And then we also, if we're unable to see the extent of the transformation zone or transition zone, what we talked about earlier, the T zone, then we would also do something called an endocervical curettage. So biopsy or no biopsy, it depends on what's seen at the time. Endocervical curetting is done for the unseen if we're not able to see the T zone. The pathology will determine the next step. So sometimes we'll have watchful waiting, where we'll bring back the patient in 6 months to a year. Sometimes we'll bring the patient back for something called an excisional biopsy, also known as a cone biopsy, where we actually remove that area of abnormality and then evaluate that patient every 6 months to a year after the healing process. So in terms of this patient, the colposcopy with biopsy showed moderate dysplasia or CIN2. There was a recommendation made for excisional biopsy or cone biopsy. And then follow-up testing is recommended in 6 months. If the HPV is again positive, then this whole thing will sort of have to go on again. They'll check cytology and determine whether or not there needs to be another colposcopy. And then depending on what is found there will determine what the next step will be. So case 3, and I promise you that this is the last one. A 53-year-old with positive HPV-16, so that's one of the more aggressive high-risk HPVs, who's had a history of cone biopsy for moderate dysplasia 6 months ago. So colposcopy with cytology was recommended and was performed, and the results revealed a high-grade abnormal cytology, severe dysplasia, which is considered to be a premalignant change. So there were 2 recommendations made: another cone biopsy, excisional biopsy, or hysterectomy. Obviously, hysterectomy would pretty much take care of the issue down in the future. The cone biopsy would be something that would be done if the patient really did not want to have a major surgery. Either of these choices are appropriate, but once again, the physician needs to explain the caveat of having an excisional biopsy, and that means, you know, pretty much cytology testing in another 6 months, possibly going through the same thing. If the premalignant change is again found, then hysterectomy would probably be offered, or hysterectomy, you know, has its own issues in terms of being a major surgery with all of the possibilities of issues that a major surgery entail. But once again, this is something, the point of this is that this needs to be explained. Your caregiver is obligated to give you this information and hopefully allow you to make the best decision, the best choices made for you. That is the whole point. You know, we want everyone to be well. We want everyone to be safe, but we want everyone to understand and make great health decisions. So be aware of the basics, and that's what I tried to do today, I hope. You know, ask your health provider what test is being performed, a primary HPV test or co-testing, especially since this is new. Consider Gardasil vaccine for yourself and children. You know, I'll admit, you know, that the word vaccine right now is really hot topic, you know, when you think about everything that has gone on with the vaccines for COVID-19. But this Gardasil vaccine, as I said, it's a game changer. It prevents cancer. This vaccine is approved for ages 9 through 45. It is actually on the approved vaccines for girls and boys when they go in, I believe, and get their vaccines at ages 11 and 12, although they can get it sooner. Don't get hung up on this is something that is associated with sexual activity. Yes, you can acquire this HPV through sexual activity, but this is something that the transmission can be prevented if you already have had the vaccine, at least for those 9 subtypes. Once again, you know, it's in bold print. It prevents cancer. If your cervical screen is abnormal, make sure that your health provider explains the next steps and make sure that there's follow through with results. I can't tell you the number of times I've had patients come to me and tell me that they've never gotten results. And then when I get results, there's something wrong. Even though sometimes there might be some who've slipped through the cracks, it is imperative that you get your results, and you not only get the results, but you read the recommendations associated with those results. And I hope that this will, you know, keep us safe. I hope this will keep you safe. I hope that this has not been too long and freaked you out too much. But please get your cervical screening every 5 years, if normal. Follow the recommendations of your healthcare provider. And just as another caveat, annual physical and pelvic exams are still necessary. Just because you're getting that swab and they say, oh, you need another one in 5 years, it doesn't mean that you disappear for 5 years, you know, like, yay, I won't have that for another 5 years. You still need your annual physical exam and pelvic exam because you still need to be checked out. Your breasts still need to be checked out. Your pelvic exam is going to check your uterus and your ovaries. All of that is something that is still important and still necessary. Okay, so thank you very much for your attention. And at this time, I'll take any questions or comments. For those who are not in Chicago, that is a picture of Oak Street Beach in Chicago, and it is currently not looking like that.
No, it's covered with snow and ice. Thank you, Dr. Ray. Fantastic overview. We do have a few questions. I'm going to put in the chat a link again to the link tree. Please, please, please go down to the bottom of that link tree and click on engagement survey so that you can give us your opinion of the evening. The first question is HPV vaccination recommended, or how do we handle it for those women over 45?
Well, there are a lot of physicians who will go ahead and provide the vaccine to women who are over age 45. However, there might be some issues in terms of payment from the insurance company because of the recommendations put forward. I would say that in terms of giving the vaccine to someone over 45, you know, I would actually have to look at the circumstances. Is this someone who is currently single and still, you know, sexually active? Is this someone who's just gotten divorced and is dating again and possibly becoming sexually active with others? You know, these are all things that I think I would take into consideration. Now, if this is someone who is 45 in a monogamous relationship, that might not be someone who's going to be at risk because just because of her situation. But once again, someone who is over age 45, can they get the vaccine? Yes. Will it be difficult because of insurance issues? Yes. But as far as that person being able to get the vaccine, from my perspective, I think that it would be okay given that individual circumstance.
Thank you, Dr. Ray. The next question, we very commonly talk about women checking their breast. Is there a recommendation to check the cervix?
I would have to say no, there is not. I think that in terms of checking the cervix, that is, best done with the cervical exam. I don't think that someone checking their own cervix in terms of, placing their fingers inside the vagina to feel the cervix is actually necessary. I think that, having your annual exam is going to be good enough in most circumstances.
Okay, thank you. Would you recommend the vaccine for a married woman less than 45 years of age with a history of an abnormal pap smear?
Yes. And that's because, I realize that this person is married, monogamous relationship, but this is someone who's already been proven to have a high risk HPV, I'm assuming. And so that, so the Gardasil 9 it will not protect her against the HPV that she has, but will protect her from others.
The next question says, what about pap smears or HPV testing after you've had a hysterectomy?
Not needed.
Okay. I think you addressed it, but I just want to make sure because the question came up. Pap smears.
Can we go back just a minute?
Absolutely. Go ahead.
Because we're getting, well, you are the oncologist here, Dr. Collins. But anyway, it depends on why that hysterectomy was done. If it was done for a cervical cancer, say something called an adenocarcinoma, then yes, that is something that then there should be testing of that remaining vaginal wall over time. But for someone who's had a hysterectomy for other reasons, no, there's no reason for routine testing, routine pap testing.
Okay, I think you said it, but someone asked the question, so I want to make sure I ask it. What about pap smear screening for women over 65?
If you have always had normal pap tests, you're done at age 65. If you had an abnormal pap test 25 years ago, it was treated and everything has been normal since then, that's great. And so if you basically, the recommendations indicated, if you have had normal pap tests over the past 10 years, meaning that you've had at least 2 abnormals in a row, that 5-year apart thing, then you should be good after 65.
Okay. Is cervical cancer hereditary?
No, it is not. Okay. Cervical cancer is caused by a virus. This virus is typically acquired through sexual activity. It is, there are very few cancers that start somewhere else and end up in the cervix. So typically, I would say HPV is responsible for like 99% of all cervical cancers. Now, there are some specialty fancy cancers that Dr. Collins could tell you about that occur in the vagina and could affect the cervix. But I would say not getting into that, HPV is the cause of cervical cancer.
Thank you. That was the last question that I see in the chat or on my phone. Are there any other questions? Dr. Easton, did you get any questions directed at you directly?
No, I did not. I have not. Not that one already asked.
Any other questions? I want to make sure everybody's questions are answered. So thank you, Dr. Ray. I asked some folks in the chat what they learned, and they learned about colposcopy. They learned about the new screening guidelines. They learned about the vaccine and how important it is for our children to get it. So thank you for that. As we close, I want people to also understand that when we talk about HPV, we're talking about precancers of the vagina, of the vulva, of the cervix. We're talking about cancers of the vagina, of the vulva, of the cervix. But we're also talking about cancers of the rectum, of the penis, and the mouth. So when we talk about HPV vaccination, we're not going to only prevent cervical cancer, we're going to prevent so many other cancers. And so I think that is also very important that we remember tonight. So thank you very much, Dr.
And genital warts.
Yes, and warts,
And
absolutely.
genital warts, so.
Which is, in some cases, if you talk to patients, is much worse than having cancer.
Oh, yes.
When you can't get rid of them. So thank you very much, Dr. Ray. Thank you for those who put what you learned in the chat. My goal always is that everybody takes away one nugget that they didn't know when they came to the session, because our goal with these is community awareness and education, and that's what we did tonight. Peyton, I see you. Are you going to be our representative that will give comments from Jeff? I will turn it over to you. Thank you, Dr. Ray.
Thank you very much. Thank you, everyone.
All right. Hello, everybody. Hello, everybody. I am Peyton Terrell, and I serve as the Community Engagement Assistant and Social Media Coordinator for the DREF Research Matters for All of Us initiative. On behalf of DREF's Executive Director, Ms. Cheryl Thomas, and the entire Research Matters team, I would like to thank the community partners, the speakers, our New Orleans and our Chicago citywide coordinators, and their volunteers for putting on such an amazing event. I would also like to thank all of you in the audience for tuning in. And I believe I saw earlier our program manager, Dr. Alicia Rusty, popped in. I don't know if she's still on here. And I do see that we have our medical expert, Dr. Kimio, online, who actually created this citywide coordinator program. But as the coordinators mentioned earlier, precision medicine is the future of healthcare. Our community has been left behind in so many other aspects, and we simply cannot afford to miss an opportunity to contribute to something as important as precision medicine. So I invite you all to learn more about the All of Us Research Program. The All of Us Research Program is building one of the most diverse health databases in history. And luckily for our community, researchers will use this data to learn how our biology, lifestyle, and environment affect our health. This may one day help them find ways to treat and prevent disease. For more information about the All of Us Research Program, please visit joinallofus.org/DREF. Again, that's joinallofus.org/DREF. Thank you all so much. And now I will turn it back over to Dr. Easton and Dr. Collins.
Thank you very much, Peyton. Again, the survey link tree is in the chat if you have not done it. We would appreciate if you can do it. Please stay tuned, at least for Chicago. We will be line dancing for life next Saturday morning, so feel free to join us. Dr. Easton, when is your next program?
February 12th, Saturday, February 12th at 10 o'clock. And we will also be doing some physical fitness, not necessarily line dancing, but we're going to get it moving.
All right, so feel free to join us. Again, thank all of you for taking time out to join us this evening. And as I always close out, yes, we are in the middle of a pandemic. Continue to wear your mask and get boosted and vaccinated if you have not. Have a great evening, and thank you so much for joining us.
Thank you, Yvonne.
Thanks, Dr. Ray.
Thank you, Yvonne.
Fantastic job.
Yes, it was awesome. Wonderful.
Thank you very much. It was nice meeting you.
Nice meeting you too. And we got you captured on Facebook Live. So we'll send people. We'll keep sending people there for the presentation. It was wonderful.
For prosperity.
That's right. That's right. All right. Let me
Great job, guys.
Hey there, Dr. Williams. How you doing?
Hi, how you doing?